This is a 33-year-old white male who is actually enrolled in our MAT program here at New River. He was diagnosed in 2021 and had been diagnosed several times prior to that and was negative, which is good to know. He was diagnosed when he was in a rehab recovery center, so he did not get treated there. And he has over 40 days now, 60 days of sobriety in our program here, but also 3 months prior to that. Just an interesting side note is that he used to climb trees for a living and fell once and had trauma to his liver in 2016. His risk factors are both IV and intranasal drug use. Started with cocaine intranasally when he was 13 and then IV at age 27, and he has some non-professional tattoos. He was not sure about his Hep A and B status at the time that I saw him for the visit. He's in a stable relationship. His partner has hepatitis C. She's pregnant and will get treatment after delivery. He attends our local drug treatment court and he does maintenance work. You can see his medications there are Seroquel and Requip. He does have insomnia. He so here's his Hep A and B status. So he was positive for Hep A antibodies, but this was interesting. So his, and I think I have numbers later, but for Hep B, he was core antibody positive and he was surface antibody positive, but it was read at, oh, there's the number. It was read as below threshold at 3.6 and surface antigen negative. So I would like to ask about that when we come to the end. His labs, you can see that his CBC was normal, his renal function is normal, PTINR normal. He had a little bit of elevation of his ALT/AST. When I saw him, his APRI score was 1.05. His child Turco-Q class A, MELD score was 8. His iron studies were normal. His vitamin D was a little bit on the low side. Within the normal range, but low. I can't remember if I started him on vitamin D or not. I'll look into that. AFP was 4.8. He's HIV negative, genotype 3, and his viral load was 1.9 million. So the serum fibrosis marker was F4, and on his FibroSure, and I did a FIB4, which was a 1. And so stage 1. So I have elastography ordered. I don't think he's gotten that yet, but there's just like such a huge discrepancy. I thought that was unusual for it to be quite so huge. So I'm kind of relying on the elastography to give me an answer. I mean, I know he's genotype 3, which he could have progressed more quickly, and I know that he could have been infected as long ago as 20 years, but at any rate, it will be interesting to see what the elastography shows. Let's see, did I get all his labs? I think I did. So that's my big question, is about this this discrepancy on his fibrosis/cirrhosis stage, and then also about the Hep B seropositivity. All other things being equal, I would treat him with probably Mavorite for 8 weeks. And then can you scroll to the bottom again, whoever's scrolling for me? Thank you. I forgot what my other questions were. Treatment with Epclusa or Mavorite, and then I'm assuming monitoring based on what we figure out about his the status of his liver. I think that's everything.
Awesome. Thank you so much, Jennifer. Any clarifying questions for Jen about her case? Everyone's welcome to chime in or chat in the chat box.
Hey, Jen, it's Kaylee. Do you know anything about alcohol use with this patient, or when he had his last negative Hep C test?
He does not use alcohol, and I don't know when his last negative was. None of it make that FibroSure result just doesn't make sense. Really.
Oh, thank you.
Any other questions from the group? All right, and recommendations or feedback about this case, and I'm happy to pull it back up if anyone needs to refer back to the document.
I guess I'll talk if no one else wants to. Yeah, Mitra, can you pull it back up just so I can reference it? I didn't print them out today. Jen, I want to commend you first for gathering so much information about his fibrosis. So, you know, we always talk about trying to obtain as many modalities for assessing fibrosis as possible to get a real picture. And you did the APRI, the FIB4, the fiber test, you've got an elastography scheduled. So I'm super pumped that you did everything. That's everything I would have looked at with this patient. I would actually be, he worries me a lot, actually. This is somebody I would not be quick to treat without ensuring that he's going to follow up with close monitoring and also get without or before you do the elastography. The reason being, so this is a patient with genotype 3, which, like you mentioned, he's got the one that we worry about, the one that tends to progress in terms of causing fibrosis at a faster level and cirrhosis. Now, I mean, he's young, and it doesn't seem, just looking at his data, that he has any other real risks for liver disease progression. But that F4 definitely alarms me. I would say that remember with the two main caveats that we think about with treatment, when you have a genotype 3 patient with cirrhosis or F4 fibrosis, when you're using or considering Epclusa as treatment, you actually have to get that baseline NS5A resistance testing. Just a reminder what that is. So remember with Epclusa, it's actually comprised of two components. So your NS5A inhibitor, the valpattosvir, and then the NS5B inhibitor, the sofosbuvir. What can happen is with genotype 3, there's often a polymorphism with that virus that can create more inducible resistance, especially with NS5A inhibitors. And it's been shown that there's a lower chance of achieving sustained virologic response in individuals, especially that have genotype 3 and cirrhosis, when using an NS5A inhibitor such as valpattosvir. So with that being said, I wouldn't ought to treat him with that one unless you're going to obtain that testing, which it's expensive. A lot of labs don't know how to process it. It's a pain in the butt to order it. So I would say if you're going to treat him, I'd recommend the Maverick for 8 weeks, which is what you had suggested as well. But I would wait until you get that elastography back to really further clarify his fibrosis. We've actually seen a lot of patients where we've had really discrepant markers, and we want to always believe the more optimistic one. But I'd say in this case, let's use the more pessimistic value. I'd also tell you, because you mentioned about the FIB4 and that big discrepancy. So his APRI is elevated to the point where it also suggests advanced fibrosis. The FIB4, interestingly, is not accurate in individuals under 35 or older, or how old is he? 32, 37?
33.
33, under 35 or over 65, because those populations weren't studied when they were looking into if those calculations were accurate or not. So it's not even useful with him. I still calculate it, I mean, but it's really not useful with his age group. The other thing that's worrisome to me is his isolated core Hep B core positivity, which you mentioned as well. So in these patients, he doesn't have active Hep B, but he has Hep B exposure, and he did not develop an antibody response. So he is somebody that we worry about when you treat, he could potentially flare. It's only been shown to happen about 2% of the time in people that have his serology, since he doesn't have active Hep B. I would say, though, if he is cirrhotic, he's somebody I would probably bring in 2 weeks and check liver enzymes and a surface antigen, and then bring in at week 4, probably every 2 weeks to a month during and after treatment, because they can still potentially flare even after treatment. If his elastography is also consistent with advanced fibrosis findings, I would actually recommend, in addition to you treating his Hep C, he also have a GI consult. And that's more so to look into other potential causes of liver disease, since he's so young. Potentially hasn't had Hep C for that long, since he's reportedly had negative tests. We don't know how long ago those were done. But I would make sure that, there's nothing else that could be causing his fibrosis to be advancing at such a fast rate too. And then surveillance, sorry, I'm talking forever, but surveillance. So every 6 months, I would recommend either a follow-up liver elastography or a right upper quadrant ultrasound. Since he's F4, I would also say, in addition to cirrhosis labs, so also monitoring CBC with DIF, PTINR, and complete metabolic panel as well. And that's more, right now he looks very stable. So even if he does have cirrhotic tissue, his disease is well compensated, but just so that you're monitoring ongoing stability of his fibrosis.
That is so helpful. I mean, he really brings together a lot of things that I've heard you guys talk about in the didactics, but I've never really had to manage. So it's, I'm learning by doing. You said bring him in 2 weeks, and then how often for the surface antigen and the DNA?
So with isolated core, the way his serology looks, like I said, it's really low chance of reactivation. It's only 2%. If he had surface antigen positivity, there's a much higher chance he would reactivate. My comfort is I typically like to check it at 2 weeks, 4 weeks,
okay,
6 weeks. And then, he's only going to be on 8 weeks of treatment.
Yeah.
So I'd probably still check it either end of treatment and then a month after.
Okay.
And then SVR12 certainly, because they can still potentially reactivate. That's probably potentially even too close of monitoring, but that's just my comfort if he's willing. Plus, then he can kind of keep closer eyes on him
Yeah.
too. But really a hepatic panel, and then if that becomes elevated, you can check the Hep B surface antigen to see if there's a flare.
Okay, that's really
It's
helpful.
a great case. Thank you so much. He was really kind of
Thank you.
encompassed a lot of things at once. So thank you so much for sharing him.
I appreciate the guidance, because I'm just hoping for this guy. I was hoping that everything was wrong. But we'll see. He's doing great in his recovery, and he has a baby on the way. And so I want to give him the right care. So thanks, Kaylee. I don't have any other questions.
Awesome. Thank you so much, Kaylee, and thank you for the case, Jen. You didn't have any other questions you said about this case, Jennifer? Awesome. All right, so if you're okay, we'll have Dr. Leonard do his case, and then we can have you do your discussion, and then Dr. Gofus's didactic. So Dr. Leonard, if you're ready, I'll go ahead and pull up your case for you.
Sounds good.
Right. Are you able to see that okay on your end?
Yes.
Awesome. I'll turn things to you now then. Thank you.
So a little bit different case, but I had a 12-year-old girl who came to me in July as a brand new patient, and came to me predominantly with lower leg pain, so below the knee, bilateral leg pain. They said she had some edema and some redness in that area, but her exam was normal on the day that I saw her. I had been diagnosed with growing pains at the age of 5 or 6, and she's been having pain intermittently since the age of 5 or 6. She complained a lot of vague complaints, vomiting, diarrhea, muscle aches, and on note, she is less than the first percentile for height. They had Mom had been checking her sugars just because an aunt had diabetes and found a low sugar first thing in the morning a few times. I don't know how that fits into her case, but that was just another part of this girl. So I had several concerns for this girl. First and foremost, do we have a consolidating reason for her to have all these complaints? So in addition to all the labs that you see, I did get a Lyme with it, and her Lyme was positive. Of note that I did not expect is her TSH is to be quite low, and her free T4 was normal though, and you can see that her thyroid peroxidase antibody was elevated, but her thyroid stimulating immunoglobulin was low. So it looks like she has autoimmune hyperthyroidism as well. And I tried to get things looking at her growth. And if you scroll up just a little bit, her inflammatory markers were quite high as well. So just trying to look through and find some literature, I found a couple cases where the Lyme disease has been associated with or found with autoimmune thyroiditis, and I think that's what this girl has. So I put her on doxycycline. I treated her for 28 days because of the leg pain, associated swelling they felt that they had seen, and she resolved all of her symptoms last I knew, but she has not followed up, which she is due this month, and she has not gotten repeat thyroid studies to know how her thyroid has responded after we have treated her Lyme infection. Can you scroll down? Yeah, scrolling down. She was at 10. Oh, excuse me. I did 14 days of doxycycline, not 28. I did see her in association with another sibling's visit, and that's when she told me that she was actually back to normal. No more hyperthyroid symptoms with the diarrhea, and no more leg pain, no more myalgias, no more anything. As you see there, her CBC was pretty normal. You can scroll on down. CMP. Yeah. And so my big question is are we seeing quite a bit of other autoimmune diseases, specifically thyroid disease, in association with Lyme disease or caused by the inflammatory response that is activated secondary to the Lyme infection? I was hoping to have some follow-up information and to know what her thyroid is, but she hasn't had that done. So that's all I have.
Thank you so much, Dr. Leonard. Great case. We'll open up for any clarifying questions from the group about this case. And any feedback, recommendations from the group on next steps for Dr. Leonard?
Oh man, I unmuted, but that doesn't mean I have anything useful to say. Dr. Leonard, you're so smart. I always get nervous when you ask me a question because I'm not going to have an answer.
Oh boy.
But no, here's the reality. This is why I love Echo, because it's a two-way street. I can answer your question about how common this is by saying that neither myself nor any of my colleagues, including ones who didn't train here, including one who trained up in New England, had never seen it. Have never seen thyroid disease related to Lyme, number one. Number two, it's an eye-opening concept you raise, and I probably will add a TSH onto screens for patients I see with a predominance of generalized complaints and positive Lyme serology. If we step back, take like a couple steps back and look for biologic plausibility, just in infectious diseases in general, the thyroid is a frequently affected gland, or a frequently affected target tissue by collateral damage. We all know that. You know, there's a viral induced thyroiditis is you get a cold and then you get a transient, you know, hyperthyroidism followed by hypothyroidism, blah, blah, blah. We also know that during more chronic syndromes that induce autoimmunity, including the namesake of our echo session here, you know, Hep C and HIV, both of which commingle with autoimmunity due to that frustrated immune response and B cell stimulation, and you can get a lot of thyroid dysfunction in the setting of any of those chronic illnesses. Now, you know, Lyme disease has never been one of them what's crossed my mind, but you're right. That's when PubMed and Google come to the rescue. And prior to you asking the question, I wouldn't have thought to ask it myself. And you're right. There's actually not only theoretical biologic plausibility, there's specific data that demonstrates a molecular mimicry from some of the antigens on the Borrelia species and the thyroid. So there's a big picture as well as specific credibility to this. When I look at the case reports, most scenarios are a transient thyroiditis. So more following the concept of a transient hyperthyroid followed by a transient hypothyroid followed by resolution. And however, there are Hashimoto's type destructive thyroiditis is also described. So I commend you for thinking about her aches and pains and swelling and thinking about Lyme, and clearly having a good response to therapy is cool. I in general don't see elevated SED rates in most patients with Lyme disease, including those with Lyme arthritis, except for the patients who have a significant degree of autoimmunity involved. And it's interesting. So the patients who I do have a SED rate on and have a Lyme arthritis, they don't tend to do well when the SED rate's high. They tend to have a relapsing syndrome that doesn't respond quite as well to just antibacterials. So it's almost as if that autoimmunity is more significant in those patients. So I'm a little nervous in this little one you got. I don't know enough about SED rates in kids, but I do remember that it's age dependent and gender dependent, and hers should be something like, no more than 15 or 20, not very high. So, but that's all I got. So I did assay a couple of my colleagues who have worked here for a long time, and then talked to one of my colleagues who trained up in Rhode Island, and none of them have ever seen it, and more importantly, ever thought of it. And so I think you might be onto something, man. I'm proud of you. So you're changing our practice, just like we do for Hep C patients. We should check TSHs. If you get somebody with a lot of fatigue and oddness, there is this concept. Apparently, you're onto something, man. But I think it's incredibly infrequent. I would love follow up on this lady to see if she got better. This little, I don't know if you call a 12-year-old lady. She's a little lady. She's a little lady.
Yeah. Well, I mean, she's got two things going on. They have since transferred from me to one of our other colleagues at one of our clinics that are by their house. So they see Dr. Linger. They have said they're going to see Dr. Linger. So she had a no-show and a couple cancellations for her establishment with him, especially to follow this up. And we did not get a karyotype yet because I am still somewhat concerned she may have Turner syndrome because she is so short. And it definitely compared to her, she has a twin sister who's 6 inches taller, something like that, 5 or 6 inches taller. So she's got a couple things still kind of hanging out with her. Obviously repeat thyroid, and then figuring out if she's just short or making sure she doesn't have a genetic reason to be so different than her twin.
Yeah, fascinating, man. And definitely see which way she committed with her thyroid. If she's more of a, I didn't see Graves described, not a permanent thyrotoxicosis type of stimulation syndrome. That's the Lord knows with autoimmunity, who knows?
Thank you so much, Dr. Gilfus, for that feedback. Any other comments or recommendations from the group? And Dr. Leonard, any other questions about this case that you had or anything you wanted to bring up with the group?
Nope. I just need you to push on the Pete folks to get in these too.
Yeah, absolutely. Thank you so much again for this case. It's really interesting. We appreciate you. All right.